psychiatrist, the director of our research program here at ETSU Department of Psychiatry. He is also the director of our outpatient clinic, the chair of this grant committee, and I just found out that he also does some telemedicine with the Department of Psychiatry in case you're interested. He does geropsychiatry telemedicine and also some forensic telemedicine. He, for his education and training, Dr. Moore received his medical degree from Queen University at Belfast, United Kingdom. He also did some extra training there for psychological medicine from London University. He did his residency at the Royal Air Force in London, and he also has a diploma from the American Academy of Pain Management. So welcome, Dr. Moore.
Thank you very much. Now, first task is to get the program, and I somewhat foolishly said, okay, I'll tell you about this latest study I'm doing. I think it's interesting in one respect, that is, it will introduce to some of you a methodology that you may not be familiar with. Our study, it's a work in progress, it's a pilot study, and even starting out, we didn't think we'd have real conclusions. We're more in the business of getting enough data to do a power analysis, which would be to tell us the number of subjects that we would need in a study to get statistically significant results, and also to give us enough data to apply for funding. But this is all, I think, in itself educational for you to understand the steps that we take when we're trying to do research. One of the things that you may or may not know is that the NIH and IMH maybe about 2 years ago came out with a concern about the fact that all the research that we do in psychiatry is based on what really is probably not a valid classification of psychiatric illness. For example, genetic studies do not separate out schizophrenia, schizoaffective disorder, bipolar disorder, even the schizoid and schizotypal personality disorders. And they suggested that people applying for grants should take an intermediate step and try to do studies based on biological markers, which we have almost none. But they, for example, said that the availability now of brain imaging of different kinds could be the groups of participants that we would study. Now, this methodology that I'm talking about today has been available for most of my career, but it's still, it's an application that might be of interest to some of you. And I will explain to you a little bit more about the methodology when we progress. So the study that I'm talking about today is a pilot study of HIV-Associated Neurocognitive Disorders, and people who do this kind of research just refer to it as HAND. And you'll see that my co-investigators are Richa Svalina. I don't think she's here. I don't see her. And I will talk about in a moment. And Joseph Aikikwerwera, I don't believe he's here either. And finally, Susan Wallace, who is here. And I want to show you some pictures of these people. So this is Goricha. I always have a long learning period trying to get people's names correct, and I think Goricha is correct. But Goricha is just finished a summer research fellowship in our department every year, the first-year medical students compete for a limited number of summer fellowships. And this year, Gorica put my study at the top of her preferences, and I put her as my top candidate, so we matched. And she spent the summer with us and has been an excellent investigator. One of the things that appealed to me when I read her CV when we were doing the interview process was that she had done some research in the space race. Well, I had this imagination of her getting kitted up to get in a shuttle and take off and so on. The reality was that she had done some work, I think it was in high school, where they had put together some bugs of some kind that were taken in the space shuttle and were studied. They studied the effects of space on these. But I thought, well, that's wonderful that she had that initiative and had done that kind of work. So the next person is Joseph. And Joseph is an MD who is not yet, I don't think he's licensed, but he's not been accepted for a residency, and he wants to do psychiatry. So he has spent since January with us. He's been a wonderful colleague. He's very full of initiative. He gets out and gets on with finding participants and so on. And by the way, I could not do all the research that I do without people like this doing a lot of the work for us. And then sitting up in the back there is Susan. Susan is only a half-time available person for us, and she is our sort of administrator for the program we run. So she helps out with getting people the right credentials, the right training for IRB and so on. And also she has become our go-to person for anything to do with EEGs or evoked potentials. And she's been very helpful in this study as well. I do have a disclosure. The equipment that we've used to measure the P300 is owned by a company in Kentucky, and they very kindly have given it to me on permanent loan. The equipment's worth about $33,000, so that I could not have gone out and purchased myself. And the reason I found out about it was that another of my colleagues, Tracy, she sent me an email one day and she said, oh, by the way, I think you should have a look at this study. It's on clinicaltrials.gov, and looks like somebody has either taken your idea or has come up with your idea for a study that I'm doing on Alzheimer's patients with an evoked potential, a flash visual. And I was so devastated. I went in and it said, another idea I had was that research I would do would involve a handheld device that I could take out to nursing homes or congregations and churches and so on, and do a screening of all the people who were interested. And that would tell me whether they were at risk for Alzheimer's or maybe even had Alzheimer's. And this was a study of a handheld device in Alzheimer's. And I thought, oh, I've taken too long to get to the point where I have a study. I was reluctant to read the background to it, but when I read it, I was so pleased because they were not studying the evoked potential that I'm interested in, which is the flash visual evoke. They were studying the one we're going to talk about today, which is the P300. It's also called the oddball paradigm. So having learned that they had this device, then I called them up and discovered they were located in Kentucky. Had a wonderful conversation with the executive person. He wasn't the CEO. He was working with the CEO to run this business. He was a business manager. He was a wonderful guy. He was really excited about what I was doing, and we were kept interrupting each other with ideas and discussions and plans. They invited me to go out to Kentucky. I spent a day there with them. We had a wonderful collegial discussion, and they just said to me, well, if you want our equipment, you can take it and work with it, and we'll support you in that way. So that's how this equipment came into our hands. Way, way back when HIV/AIDS was something that frightened everybody so much that even doctors, my colleagues, doctors, refused to go in and visit patients admitted to the hospital with HIV/AIDS, and it was a terrible time. The infectious disease doctor that was in our university department, I think he was a saint and still is a saint, because he didn't know any better than anybody else what the consequences were of him going in and doing hands-on examinations and so on. But he did everything. He worked with these patients, and he was exhausted. He was really the only person doing the work. And he gave the equivalent of a grand rounds, and when it was all over, I went down and spoke to him. I said, look, I'm a psychiatrist. I can't help you with the infectious diseases part of it, but I would love to join you in some way. Perhaps we could do research together or something. And we set up this plan where I would do quantified EEG, which is using computers to measure the amplitude and the frequency of just the regular EEG. And way back then, and we're talking 30, 40 years ago when this all broke, that we had this disease to deal with, I was able to publish, it was actually, I think it was an abstract I published, but I showed that even in people who were simply HIV positive, they were not suffering any symptoms that they were aware of, and they did not have AIDS. And I was able to show that in the frontal lobes there were abnormalities in the QEEG. So we had a biological marker right there, way back in those days. And ever since then, I've wanted to follow up this idea of looking at cognition in HIV patients. And finally, I've got to start on that. So this is just to tell you all that I have this equipment, and I guess I do have a conflict of interest because they're so good to me and so on. I would perhaps be influenced by that. This is another strange coincidence, but if you look at this name here, this paper is the recognized paper that you go to when you want to study hand, because this was a committee that all these people from all over the world got together and they drew up the research nosology for different categories of hand. And I didn't know this person at all until about 2 months ago when he came here to be interviewed, because he was one of several candidates who applied to become chair, and that has not yet been officially declared, and so we'll wait and see. But I thought it was interesting when he came, and I told him the work I was doing, and we had a very interesting discussion. And some of the things that he said in his talk when he was here really explained to me some of the things that I hadn't fully understood before. One of the main things I took away from his lecture, which he gave here, which was not officially a grand rounds, but it was a similar event. And one of the things that was clear after his lecture was that the HIV antiviral medications, which are so successful in keeping our patients alive and giving them a good quality of life, those modern antiviral medicines do not penetrate the blood-brain barrier. And so although the lymphocyte measures and all the measures that are done to measure progress in the treatment of HIV patients are not touching the virus, which is located in the brain. So there's a reservoir of the virus in the brains of these people who look so well and are doing so well. I have had lots of referrals to me from the HIV/AIDS clinic, and all of them have concerns about the fact that they don't remember so well, they don't concentrate as well. They're aware of problems, but nobody is taking them seriously, because look, I mean, all your bloods and everything show that you're doing fine. This is great, and it's kind of not taken seriously. And you'll find when I get to the some of the data I have collected, one takeaway message from this talk is one of the categories is asymptomatic neurocognitive impairment, ANI, meaning that you can measure neuropsychologically impairments, but the patient is unaware. so they're asymptomatic. And what I discovered that I could not find one patient in all the 35 that we studied who was without impairment, even though they were asymptomatic, meaning they're not complaining. When we measured brain function, we found neuropsychological impairments in things like executive function, attention, and so on. So it's another clinical thing for you all to take with you, that once you've got HIV, even if you're not complaining, that the brain is not functioning like it used to do. So I just mentioned the categorization. That previous slide, this is the slide where they drew up these different levels of severity. And this is a table of what they're actually recommending we do. So I was hoping to get an HIV. These are healthy HIV negative people. And clearly, they would have no domains that would be, domains meaning different subcategories of cognitive function. The domains would be things like attention, verbal memory, visual memory, executive function, motor abilities, and so on. Anything in the cortex is measured, and there's finger tapping and so on. So for the HIV negative, healthy control, obviously there would be no domains that would be abnormal. And this abnormal ADL means activities of daily living. And if any of you have read the DSM through, you'll find that it's never enough to have all of the criteria without one extra criteria, which always says, and impairment in activity of daily living. So for example, you don't have Alzheimer's disease if you can do everything. You may have a memory impairment, you may have all those things, but if it's not interfering with your activities of daily living, then you don't have Alzheimer's disease. So this is an important concept that we always have to be sure that whatever we're diagnosing or studying don't meet criteria if it doesn't interfere with activity of daily living. So then this group, HIV positive, no domains, and no impairment in activities of daily living. And you can see in the next group, these are asymptomatic, but they do have two domains. So there are several domains which I'm going to show you in a moment, and they have to have one standard deviation of abnormality. But activities of daily living, no impairment. And then the next group, mild cognitive disorder, it's the same here and here, but it's different here and here. And then finally, the HIV-associated dementia. There's now two standard deviations of difference rather than just one. I don't really want you to try to read all of this, but it gives you an idea of what the committee said they would count as one of the domains. So there are 9 different domains that any one of them would qualify for a domain of impairment. Now we have a system that is a self-administered touchscreen neuropsychological assessment tool. And we've used it in most of our studies, and this, even in Alzheimer's patients, they can manage to do this. We don't interfere with them doing the testing. We just simply tell them what to do, and then we leave it to them. And it takes away a lot of variables that creep into paper and pencil questionnaires where people who are giving them, depending on the personality, they can have different results, different personalities of the people who are administering the tests. And with this program, what we had were these 7 domains. And you can see one of the domains was attention, and another was executive function. But we measured all of these. And they don't match exactly the 9 that the committee came up with, but this is a very well tested and tried and valid instrument. So I trust this as giving valid results. So I prepared this talk about 2 weeks ago. We had 25 subjects tested, and now today we have 35. 35 people were assigned numbers and in the study. Some of them got in and withdrew almost immediately. So we don't have data on everybody, but the majority of the patients we do. And we have 6 healthy controls, not infected. And as I've said several times, which I think is really the take-home message, if there's anything useful from this lecture, that every single patient that we studied out of the 35, some of those 35 were healthy, non-infected. So after about 30 patients with it who were infected, none of them were without impairment of cognition. And then we had 9 who were asymptomatic, and we had 2 who had the same overall cognitive impairment, but these folks were aware that they were having problems. And then we had 8 who had the dementia. And here's another person that I want to, acknowledge. And he's sitting up in the back, and he's Bill, and Bill is a 4th-year medical student who is doing an elective with us. So he's only been with us for like a week, is it? It seems like a lot longer. He has been excellent. He is very, very capable at statistics and at doing spreadsheets and doing t-tests and so on. He's helped me a lot to get what I'm able to present today together for this talk. So what he's wearing here is this handheld device that the company kindly loaned to us. And the task in this P300, I'll try to explain it to you, and I'll have some hand-drawn figures to also help. But the oddball paradigm gets more complicated the more information you want to get out of it. The simple version of the oddball paradigm is the patient has the earphones in and they hear the following: boop, 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 beep, boop, 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 beep, boop, beep, boop, boop, boop. And they're told every time you hear a beep, you press the button. So he has his hand on the button here. And that's his task. And in a moment I'll show you what happens when you have the beep. You get a waveform. It's called the P300, and the reason is P is positive, 300 is 300 milliseconds. So this waveform pops up at 300 milliseconds after the input of the beep. And there's nothing at 300 milliseconds for the boops, nothing. So the old P300, as it was some years ago with the boop beep, was only measuring tension. And now we have a more modern type of input, which is what we have in this system. And there's now thrown in the mix a distractor. And the patients are not prepared for it. Their job is to hear the beeps, and they're listening for them and measuring them. But every now and again, there's a random distractor thrown in. And then there is a waveform that pops up for that distractor. And that waveform is why we've ended up with a P300A and a 300B. And the distractor is measuring attention, and the other waveform is measuring what the brain does with the information. So when you have working memory, what your working memory does is it takes just for a few milliseconds new information, it compares it with all the information stored in your brain and makes some sense of it, and that's part of executive function. So the brain has to decide quickly, is he going to ignore this? Is he going to run away? Is he going to fight? What's the information mean? And so attention, of course, is needed for executive function, but it's a separate part of the process. Now, this is what I've been telling you, but when you see here, if you just have a stimulus, you get this 300 millisecond waveform. And by the way that works is, if your EEG is just running idly, you have the equivalent of a sine wave. And if you ask a computer to draw a line through the middle of the sine waves, add all the negatives and all the positives, somebody will know what the computer come up with as a result of adding negatives and positives. It comes that line, you're right. But then the stimulus is not any longer random. And so although the rest of it is cancelled out, at this point there's a clear waveform. And the next thing is that you have here a target, and target would be the beep. The participant is told he's got to press a button for the target. And then these boops are going along, and you can see if the computer's asked to measure the response to the target, it comes up with this form here. However, if you ask the computer, well, I want you to analyze only the boops, there is no P300, but there is a 200. And the 200 is a different measure, which is not what we're interested in, because the earlier the milliseconds are, the more likely it is it's a biological track of the sensory input, whether of any of our senses, are going through different steps in the neural pathway. But once it gets to the cortex, that's when these cognitive functions start. The data's in the brain, and the brain's now trying to make sense of it and decide what to do with it. And there are other waveforms that are even further along in this process. Way out here, for example, if I said to you, Mary had a little table, that would jar. You know, that table should be there. And so if you have this incongruity, when your brain interprets that, it pops up with a waveform later. So there are all kinds of evoked potentials that measure different brain functions. So then the final version is the one I told you about, where you have the non-targets here, you have the target, and then every now and again you have the distractor. The distractor is this waveform, and that's the P300. It's back to when you just had simply an input with none of the rest of the inputs. But then for the target here, these ones, you have a slightly different waveform, which is a little bit later and not as high. And so this equipment that we are using now is automated to come up with the different, these two components of the P300. In the old days, we used to just say P300. Now we realize there's two parts to it, two different functions. And this tells you a little bit more. The P300, when you do a quantified EEG and see where is the brain activity. Excuse me, I just had to look to see if it wasn't urgent. The activity on the brain is in the central area here, which helps us when we're looking for the measurement of the P300, because we look at the electrode located right here. And for executive function and working memory, which go together, it's much more posterior, and it also the activity goes over here into the temporal lobes. And so we now can separate out these two different waveforms which are part of the P300. One interesting little thing about the P300 is that it seems to be dependent on dopamine to function. For example, there have been studies done where you have just a normal brain and you get the normal P300, but restless legs is thought to be due to a moderate deficiency of dopamine. And the P300 is much less easily obtained in people with restless legs. And then when you go to Parkinson's disease, where there's a marked loss of dopamine, the P300 is even weaker and smaller. So putting those clinical facts together suggests that dopamine is needed for the P300. I'm sorry, I just realized if I don't turn this thing off, it'll keep annoying me. So I've done that. So unfortunately, this is the full amount of information that we've got. Be careful here. Don't think that this is twice as much as this, because we're talking about 300 milliseconds here. So if we had the whole figure, it would go right down to the bottom basement here. The actual difference is quite small compared with the measure, but just to give you an idea of the standard errors, we put it together like this. So this is, the first part here is the P300A, and this is the P300B. And what it shows you is that there is an overlap with the standard errors, and we did the hard statistics, and we did not find a significant difference. But the trend is clearly there, and we've only collected a small number of subjects. So it does support the idea that the P300 does measure cognitive function, and we're comparing the healthy controls, that's the blue, with the green, which are the HIV positive patients. But this is all P300A, and this is P300B. And it was at least reassuring to see that we had a difference which didn't quite reach significance, but we're pretty sure that when we collect enough data or enough subjects, this will finally become significant. Our plan was to study 50 participants. We want 10 in each category. However, we're just testing people who walk through the door of the clinic. We're not seeking out 10 of each group, although we would have liked that. We're going to go with what we get. And so it'll be in the form of an epidemiological study of, what kind of patients are coming into HIV clinic. Well, that's it. I did warn you up front that this was not a lecture where you could go away with findings that are conclusive. And I was worried to see the three wise men in the front here, because I have a great regard for all three of them, and I was kind of worried that they would leave somewhat dissatisfied that they came here and didn't go away with a clear message. Tom. Yes. Let me go back and show you that. There he is. Bill's right beside you, the next person in the row behind you. He's the one wearing it. Correct. It doesn't appear to matter. And I, in one of my earliest studies, was concerned that a finger movement would cause a motor cortical event. And I was worried that by using a button to press that we could perhaps be interfering with the results. But I was able to show in the small study I did that it didn't matter. I'm not sure why it doesn't matter. Maybe it's a different part of the cortex and it's just not overlapping. For people who are interested in EEGs, if I go back to, if you look at this, you see the activity is highest here and here. But you have to remember that's just surface activity. And what's possible nowadays is you can actually use all that data that's been collected. Actually, 20 electrodes is not enough data. You need 32, 64, and even 128 electrodes. But if you get all that data, you can do analyses which tell you where is the source of this electrical activity. It doesn't mean to say the electrical activity is necessarily right there. It's where is the source of it that matters. And for those of you who know about executive function and working memory, All right, for students and residents, where in our brains is the location for executive function and working memory? Anybody know? Frontal lobe is right, on which part? On which side? It's on the right. So executive function is up here, and yet the activity's appearing here. You can't really say memory is only in the temporal lobe. Memory is also in the frontal lobe, and I'm sure executive function, as we heard, I mean, the brain has to look at all the stuff in the temporal lobe for the executive function to work. So the brain is not localized the way we get taught that it is, but the main location, for example, there's a great book that I love dearly. It's a tome that thick, and it's written by a man called Jeffrey Cummings. It's entirely about the frontal lobes. And what he did was he studied patients who'd had lesions in the frontal lobes, which could be strokes or brain injuries or whatever. And he parceled out what we used to talk about as the frontal lobe syndrome. When I was young, we had to answer questions about what is the frontal lobe syndrome, and we would cover everything that happened in the whole frontal lobe. Well, he was able to show subsections of the frontal lobe do different things. The right dorsolateral does executive function, whereas the inferior orbital is responsible for Phineas-Cage syndrome, where people, where it's a social control thing, where they lose that if it's damaged. And the anterior cingulate, Jeffrey Cummings was able to show, was when it's damaged, you have people who are mute and immobile and catatonic. And so we used to say all those things were part of the frontal lobe syndrome. Now we know better. Another interesting little clinical fact for you all: if you have damage to the right frontal lobe, it's most often results in mania-type symptoms. And if you have damage in the left frontal lobe, it most often results in depression. That's an interesting right-left contrast. And it's interesting for me now that I'm doing TMS, we routinely stimulate the brain on the left frontal, prefrontal area. That's where it works. And that makes sense, because if a deficiency of action in the left frontal lobe causes depression, then you would think that stimulating it would lift the patient out of the depression, and it works. We do it, and we've had really good results. So I think, go ahead, Greg. Do you would like to hold this, as people can hear you?
There was a lot, as you admitted, there was a lot of variability in the data, because we're not seeing the entire bar or all the data points. So it seems unlikely that that instrument could be used to identify deficits in executive function in populations. But if you were to follow a patient longitudinally through their illness, it may detect changes. And are you?
Greg, right on target, as I knew he would be. The P300 is very unhelpful for sensitivity, but it is very helpful for specificity, meaning if you get a normal P300, that's very useful clinical information. If you have an abnormal P300, it could be anything. It could be depression, it could be Alzheimer's, it could be any neurological disorder. So it's not, in that sense, it's not a useful biological marker, but for people who do research, it is helpful to rule out. And for example, if I was going to study a group, let's say in this study here, if my patients had a normal P300, I would be concerned, meaning it doesn't sound, it wouldn't matter, it doesn't apply so much to an HIV infection, but let's say you had a patient that you suspect it might be exaggerating their clinical condition, and you ran a P300 and it was normal, you could pretty much say, well, they don't have a major depression or one of these major illnesses. But I think the P300 is not ready for clinical use, but I think it's an interesting tool to try to understand better how the brain functions, and I think it's really for researchers. We have all that data, but I rushed to fill a gap. We don't have nowhere near analyzing it yet. But I have a son who is an infectious disease doctor, and he, with his colleagues, go out to Uganda about twice a year, and they run a big research program there on HIV/AIDS, and they do teaching. They don't do treatment, but they teach young doctors and nurses. And so I was talking to him about this grand rounds. I guess I was looking for help. And so he said to me, so what do you know about what you're saying? You know, what about all the markers of lymphocyte counts, viral load, and all kinds of stuff? And he said, because if there's anybody in the audience who is knowledgeable or who's in the infectious disease world, they'll want to know what you find in terms of the P300 and cognitive impairment related to those things. I could speculate that they won't mean a lot because what's in the peripheral blood isn't apparently measuring what's going on in the brain. I don't know where this research will take me, but some of the very early antiviral agents did penetrate the blood-brain barrier, but they had bad side effects. That's why they're not used anymore. But I'm thinking we could maybe select out the most seriously impaired people and explain the risks of going back to some of these old medicines and see what happens. There was a child that was born of an infected mother, and for some reason the mother had a course of treatment with one of the older antiviral agents, and this baby was born free of HIV. So that's one anecdotal account, but it throws up an interesting idea. Tom. Oh, interesting. Tom's updating me and telling me that that baby has relapsed since then. I don't know the answer to that, but it's a really good question to ask. I do know the P300 latency increases with age, so we have to be careful when we're doing this kind of research to match for gender and age when we're comparing groups. And I don't know the answer to that, but as you know, the visual cortex is in the occiput, right. and this doesn't get that far back. It's not that far back? No. Okay. And this is more related to the temporal lobe. Okay. And the hippocampus. I'm afraid that's just my effort at drawing a diagram. Okay. I was going to say something which I think I won't say. No, best leave it alone. I was thinking of an alternative way to present these things, and I discovered that copyright law would have involved me a cost of $7,000. So I decided I'll just do my own diagrams based on my own personal knowledge. You're going to ask a question? Well, clearly it would impair it. But I often tell my patients who are anxious, who say they can't remember, I say, well, if you can't register the information, then there's nothing you can remember. So, if you can't pay attention, you're not going to be storing the stuff that you want to remember later. Oh yeah, I think this has got the potential to do that, because the P300A is measuring attention, and B is measuring executive function and working memory. Am I getting your question right? The executive? Right. Yeah, I'm sorry this thing keeps going off. I'm trying to stop it. Just, if you don't mind. Yeah, I see your point. It's a good point. It may be that executive function is not itself impaired. It's only impaired as a result of attention being impaired. And that's good subject for another few years' research. I don't think we know the answer to that. Not these people. This is my first entry into this P300 work, and this is just the start. I'm not sure where it's going to take us. I have done P300 work in the past, actually, but I did it with schizophrenic patients. And when I did that study, I really wondered, could schizophrenic patients actually do the task? And they did it very well. And but what we did show, we showed a couple of very, I think, interesting things. I did that study as an add-on to a commercial assessment of an antipsychotic, a new antipsychotic in schizophrenia. And the antipsychotic worked. It was marketed eventually. Well, what I showed was that when our schizophrenic patients responded to treatment, their P300 came back to normal. So that was very interesting. And so the P300, in that sense, can also give clues. Just as a clinical story, I had a very, very psychotic schizophrenic patient that I took care of clinically. And he came in on one occasion extremely psychotic. And I went to see him on the first visit, and he was unable to communicate with me. And for some reason, he took my hand, and with his other hand, he used his finger to follow all the veins in my hand. And it was a very kind of affectionate thing he was doing, and he was communicating in some way with me, but he wasn't able to have a conversation. And maybe a week later, when he had made very good progress and when we were now communicating, he told me verbatim some of the things I'd said to him on that first visit, which amazed me, because I thought there was no way that his cognition would allow him to remember all of that. So schizophrenia is a fascinating illness, and you get surprises clinically. Well, that's another good question which he's raised, and it's some of these measures, and I'm thinking of another, actually not the P300, but I do research with a visual evoked potential in Alzheimer's disease, and in Alzheimer's disease it is delayed. And to date, I believe it's not delayed in other kinds of dementia, which, if it's true, is a remarkable finding, and I'm hoping to prove that before I retire. But here's the thing, that to answer your question, when you look at patients who were on anticholinergic drugs, we don't use them quite so much now, but when we did, they had a real delay in the visual evoked potential. And when they took away the cholinergic drugs, it went back to normal. This is a visual evoked response. Now, why would it be of any significance in Alzheimer's disease? Well, the reason is there are two visual pathways in our brain. There's a really old visual pathway, which takes care of things like movement and contrast. And that's when we needed to be aware of threat from an animal and so on. And then there's a more modern visual pathway which takes care of color and detail. Now, the old pathway, it requires among its neurotransmitters acetylcholine. But the more modern one for color and detail does not involve acetylcholine. So it makes sense that if you're lacking acetylcholine, as you are in Alzheimer's disease, and one of the neurotransmitters is acetylcholine, then you would expect that that visual evoked response would be delayed, which it is. And so that also would explain why patients on Cogentin would have a delay. And so they're very, very much dependent on neurotransmitters. There's a guy called Mark George who invented TMS, works in South Carolina. And I am the editor of a journal on EEG. And I approached him and invited him to be a guest editor of our journal and devote the whole issue to transcranial magnetic stimulation, which I'm delighted to say he did. And the beauty of doing that is that I would never be able to attract all the leading authors in the world to do a special issue, but he, being the guest editor, was able to pull in all these great authorities, and we had a wonderful issue of the journal. So when he sent me his editorial as the guest editor, I was delighted to see what he said, because he said, until recently, he thought the brain main mode of function was with chemicals and neurotransmitters, but he has now gone away from that, and he thinks the brain is entirely, or not entirely, but it's more dependent on electrical activity and electrical circuits. And I think circuits are the key to a lot of what goes on in the brain, which goes back to Tom's point that the frontal lobe is quite away from the P300B, but we can't localize activity in the brain the way we would like to. These circuits are involving different areas of the brain. And at some time we'll be able to start studying that. There's a new type of MRI which is capable now of showing up the white matter pathways in the brain. And it's not available clinically, but it's throwing up a lot of interesting information about things like concussion and other disorders that we're dealing with, but we don't understand. So I think I've talked enough. If there's any other questions, you're welcome to come down and talk to me afterwards. But thank you for being such an interested and generous audience. Thank you.